Hello, and thank you for taking the time to learn more about this important public health strategy plan. Today, you will hear from Stephanie Komasinski, myself, Sharon McClellan, and Stephanie Taggart on a strategic plan designed for national Jewish health that will improve air quality and expand equitable access to respiratory care across Colorado. As a nonprofit academic medical center based in Denver, Colorado, National Jewish Health's international status makes it recognized as a specialty clinic and hospital for respiratory care. Since opening in 1899, National Jewish Health has grown as a globally recognized institute that combines clinical care, research, and education. Today, National Jewish Health serves adults and children from across Colorado, the United States, and internationally through advanced pulmonary allergy, immunology, cardiac, diagnostic, and clinical trial services. This history matters because it shows that National Jewish Health already has the expertise and infrastructure needed to address Colorado's current respiratory health challenges. This project builds on National Jewish Health's existing mission and revises it to fit the needs of the strategic plan to focus on the residents of Denver and San Luis Valley to heal and educate through accessible and environmentally equitable respiratory care for communities affected by poor air quality and structural barriers to care. National Jewish's revised vision will now aim to lead globally in respiratory science and care while advancing environmental health equity. This plan also encompasses 8 guiding values of National Jewish Health: healing, discovery, science, health equity, education, partnership, environmental stewardship, and innovation, which help define both what the organization does and how it should serve high-burden communities across Denver and the San Luis Valley.
Hi, my name is Stephanie Komasinski, and I will be walking you through the public health problem. To start, NJH is the only hospital system dedicated to advancing respiratory disorders and continuously works towards transitioning to preventative care measures. The problem statement is as follows. Despite Colorado's known reputation for having a safe and healing climate, residents of Denver and the San Luis Valley are subjected to worse air quality, subsequently increasing the prevalence of asthma and COPD. Yet, low-income or minority residents lack the resources necessary to obtain access to the state-of-the-art respiratory care that NJH provides. Moving into a brief history, both areas have high air quality index rates, which can lead to higher rates of asthma and COPD. Therefore, these areas have an estimated 10.4% increase of these conditions due to the AQI rates. Finally, current challenges revolve around the social determinants of health. Many low-income and minority residents face significant financial strain when it comes to accessing NJH's respiratory care, which can manifest through accessibility issues due to a lack of reliable transportation to get to appointments.
This strategic plan depends on strong stakeholder engagement because improving air quality and access to care cannot be achieved by a single organization alone. Key stakeholders include patients and families with asthma and COPD, National Jewish Health leadership and staff, community health providers, safety net clinics, state and local agencies, schools, community organizations, and funding partners. Each group plays a different role, from sharing lived experience to supporting implementation, outreach, coordination, policy alignment, and long-term sustainability. Because their power and interests differ, engagement must also differ, with high-power stakeholders involved in planning and metrics, while community groups engage through advisory boards, focus groups, education, and co-designed interventions with individuals and families that suffer from COPD and asthma.
Hi all, my name is Stephanie Taggart, and I will walk you through why this crisis is urgent and why NJH is uniquely situated to lead the response. Colorado's air quality crisis is not theoretical, it is documented, worsening, and happening right now. The EPA reclassified the Denver Front Range to a higher ozone non-attainment status in 2024, and the communities absorbing the worst of it are Latino, Indigenous, and low-income residents who already face the greatest barriers to care. Rising costs lock people out of specialty respiratory services. Broadband gaps in the San Luis Valley limit what technology can even do. This environmental scan tells us exactly who is being harmed, why, and where NJH has both the responsibility and the opportunity to act. The crystal analysis breaks that landscape into 6 strategic forces. Politically, Colorado's ozone crisis has opened a policy window, and NJH is positioned to be the scientific voice in that room. Economically, financial instability directly predicts COPD, which means access and affordability are clinical priorities, not just social ones. Socially, language barriers and limited health literacy delay care for the population with the highest disease burden. Technologically, telehealth can expand reach, but only if we pair it with device lending and digital inclusion to prevent it from widening the gap. Environmentally, Denver's failing AQI grade and the legacy of historic redlining demand we treat this as an equity issue, not just a clinical one. And legally, SDOH, social determinants of health, housing, income, education, and transportation are the documented root drivers of respiratory disparity in Colorado.
Let's discuss the SWOT analysis. The internal strengths include NJH's mission and vision, fostering community trust and reliance on robust research infrastructure that can lead to better health outcomes for patients. Their integrated model of care and health education system allows for the delivery of community-based air quality literacy to hard-to-reach populations. The internal weaknesses include NJH's recent discontinuation of DEI programs, bringing into question the prioritization of equitable care for minority populations. Additionally, there is known clinical distrust in vulnerable populations, and the issue of SDOH barriers like cost and the location of NJH's facilities is prevalent. The external opportunities include the potential for an increase in equitable healthcare for minority and underserved populations. This change can therefore lead to improved health outcomes as a direct result of increased access to and affordability of care. Finally, the external threats include continued SDOH threats like financial strain or social barriers, because a successful strategic plan can only be implemented if the population can access and afford the services the plan is advocating for. Additionally, the potential for higher AQI rates and a higher prevalence of chronic conditions would likely necessitate a shift towards risk management.
3 priorities drive this plan. First, health literacy. Communities that understand their risk make better decisions and use fewer emergency resources. Culturally responsive education is both equitable and cost effective. Second, expanded access with technology and innovation through FQHC partnerships, sliding scale services, and mobile screenings that are executable within 1 year. Third, policy engagement. NJH must be at the table shaping air quality standards, not just treating the patients harmed by them. These 3 priorities align with our mission, our data, and our community's urgent needs. All of these are not just aspirational. Every target is measurable, and Stephanie K will explain how next.
The defined SMART goals are designed to be achieved by June 30th, 2027. The first goal revolves around implementing a 6-month-long health literacy program and assessing an increase in health literacy rates as measured through pre- and post-assessments, and results may vary based on socioeconomic and educational status. The second goal focuses on increasing accessibility through establishing care access points, enrolling patients in a sliding scale, and hosting screening events in geographically convenient areas for the population. Finally, the last goal has 2 defined deadlines. The first focuses on developing partnerships with lobbyists and submitting policy recommendations, aiming for inclusion, acknowledgement, or legislative action. The second deadline focuses on putting those efforts into action to expand community solar access for the target population, increasing healthy indoor air, and reducing fossil fuel use.
To bring these 3 goals to life, our implementation plan addresses staffing, funding, partnerships, barriers, and sustainability. Staffing is goal specific: bilingual community health workers and health educators for goal 1, telehealth coordinators and mobile clinic nurses for goal 2, and a policy analyst and lobbyist partner for goal 3, every role tied to objective level metrics. Funding is diversified across federal and state grants and resources, philanthropic support, and Medicaid managed care contracts. Partnerships are named and contracted: the Colorado Health Literacy Coalition, FQHCs, Earth Justice, and the San Luis Valley Rural Electric Co-op. Known barriers such as language access, geographic isolation, and political risk are managed through quarterly risk registers, all with a unified KPI dashboard tracking all 3 goals toward an annual equity and impact report. We measure everything, and we use what we find. Evaluation is built into every phase. On a quarterly basis, NJH leadership will review a unified KPI dashboard tracking all metrics and objectives, enabling course corrections before outcome windows close. Within 6 months, we expect 75% of health literacy participants to show a measurable improvement, at least 150 patients enrolled in sliding scale services, and 3 or more evidence-informed policy testimonies submitted to the Colorado General Assembly. By month 12, success looks like sustained self-management among program graduates, reduced emergency department utilization for asthma and COPD, and adoption of at least 1 NJH-supported ozone policy targeting high-burden communities. We're using 3 frameworks in sequence: the CDC logic model to make our theory of change explicit at design, re-aim at 6 months to surface who is and who isn't benefiting, and the CDC evaluation framework throughout to ensure findings are used, not just reported. Handing back to Stephanie K to review the plan's budget.
Here you will find our budget summary, which includes a total program cost of $852,841. Personnel category is based on the salaries for a program director, community health workers, and outside advocates. Program costs include toolkits, a telehealth subscription, and portable pulse oximeters to satisfy the strategic priorities. Contractual services include policy advocates to satisfy our third strategic priority. The final two categories include online marketing tools and survey or management assessment.
The data makes the case. Denver's red line communities breathe the worst air in the metro. Colorado violated EPA ozone limits 40 times in a single summer, and 10.4% of Coloradans are living with asthma, many without access to the specialized care only NJH can provide. This plan is NJH's answer, an investment targeting the root causes of respiratory disparity, not just their symptoms. The framework is built, the partners are ready, the evidence is clear. We are asking you to invest, to partner, and to advocate so that clean air and equitable respiratory care become a reality for every community in Colorado. The time to act is now.